Welcome everyone to our sort of weekly live show that's designed for river guides. The idea of this show is to bring an expert in some sort of field that can help share information with river guides who want to be professionals. And this week, I'm stoked to have Chris Davis on the show. Chris Davis, MD. He's an assistant professor of emergency medicine and is associate director with a wilderness. I'm sorry, I'm reading this off of my email. I don't even know. I'm not sure what this stuff means. What's an associate director of wilderness medicine fellowship? What is that?
Oh, yeah. So we've got a training program at Wake Forest where we take emergency physicians who finished their training, 3 years of residency after medical school to be experts in emergency medicine, and an additional year of training where we kind of take them and teach them the skills they need to be experts in wilderness medicine. And that is, both technical skills. We take them out and teach them the fundamentals of swiftwater rescue, high angle rescue, and then some academic skills about how to be researchers and teachers and things as well. So it's I'm the associate director, so I'm not the director, but I'm an associate of the
right there.
So, yeah.
And so we did a podcast with you like about a month ago that was really fun.
Yeah.
I learned a lot about emergency, like wilderness medicine. Talking to you, got to ask you some cool questions, and I really wanted to dive into drowning after that talk. And you were super into that. You already had a presentation you thought about, and I think this is important for guides because we learn about drowning in a woofer class or in a general environment, not specifically to whitewater, and so. Yeah. I'm excited for you to do a presentation that's sort of designed for river guides around drowning.
Yeah, absolutely. I mean, I'll get into it specifically in the presentation, but for the typical woofer course and things that people take for most outdoor guides, water is really not in play. I mean, if you're, a backpacking guide or you're taking people rock climbing and stuff, drowning is an unexpected, unusual sort of event. But for us on the river, that's like the big thing that we worry about. So I think for us that work on the river, we should really, really know a lot about drowning. That's the big thing that we're worried about when we've got our guests out there. So we're ready to get started. I'll take you guys a little bit through drowning. I won't be able to see your comments or anything until the end, but Zach will hopefully fill me in here. So we'll see. This live stream thing is pretty new for me, but kind of excited to embrace some of this technology as we all figuring it out. So just a little bit about myself first. I'm a boater also. My background kind of growing up was in racing, like a lot of the Southeastern kids. I did slalom and was on the Wildwater team for a while. They were racing C2. I think it was in 2003 on the Kern River. And I've always been a sea boater. I started in slalom C1 and, continue to just got stuck on that. And I continue to do that, still paddle, even creeking and stuff like that. Single blade and open boat and stuff as well. Occasionally kayak, but that's kind of what my background's in. But I've definitely spent some time on rafts as well. Did some raft guiding, just some day trips, never, big multi-day trips, never out west or anything. But in the last few years, I've been really getting into big multi-day trips and trying to spend a lot of time rowing, which I found is super fun. And that's me on the Maine salmon a couple years ago in the fall, feeling like a real American there with the eagle mask on. So in my professional life too, we were talking about a little bit the Wilderness Medicine Fellowship. I'm an outdoor educator for doctors is a big part of my job. Here we are, kind of our local cliff. I'm teaching our current fellow, one of who's also an emergency physician, about caring for patients in high angle environment. And I also kind of still get my hands dirty in the field. I fly on our air medical service there. That's one of our aircraft at one of the local trauma centers, kind of looking out over our nice Blue Ridge Mountains. So that's just a little bit about me. We're going to talk about today, though, is what kills boaters. I mean, we can talk a lot about just wilderness medicine in general, and different injuries and things that you may encounter as guides out there. But really, when you start breaking down the stuff we're really worried about, it's drowning. So this is a really cool chart that you can go interact with on the American Whitewater webpage under the accident database site. This kind of looks at all the fatal accidents that happened. And I think this was over about 50 years or so, 60 years. And you'll notice there that every single one of these things, not every single one, but most of these things, if you look at any measurable percentage here, involves drowning. There's this big category kind of at the top, flush drowning, which we'll get into specifically and what that really means. But PFD not worn, that sort of assumes that the person drowned. Pinned against a strainer, caught in a low head dam, swam into a sieve, pinned in a boat against something, foot entrapment, which is interestingly very low percentage of things relative to the amount of time we spend thinking about it and training on it in swiftwater rescue. But if you look at these big measurable things, they all involve drowning, and that's the big thing we're worried about. And some of those things are things we can modify, right? We can put on a PFD, right? If you don't have your guests wearing PFDs, I don't know what you're doing, but that's one of the big, 15% could have potentially been prevented by not wearing wearing a PFD. But, there's some other things that aren't measured in here that we know from just the general drowning literature is really important. Alcohol use is one of the things that's very, very commonly cited as a contributing factor to drowning. As well as, the water temperature, other things can really play a part in that. So, if you fall down and you break your wrist, or you get a bump or scrape, or you get stung by a bee, provided that you don't have an anaphylactic reaction and die from that, most of those things, which are common injuries, really aren't that big a deal. If you have a guest scrape their leg or get a cut or something, that may not even ruin their day. They may still have a great trip, even despite, getting a burn or a cut or something like that. But drowning is really the thing we want to avoid, obviously, because this has the highest potential, if we look at this chart here, to actually kill somebody that's on a trip with us. So what is drowning? It's really not as complicated as it's been sort of laid out to be over years. You may have heard some of these terms before. Just, you can throw anything out here if you've got any comments about this, but you may have heard of delayed drowning, secondary drowning, dry drowning, near or wet or passive or flush drowning. All of these different things, they kind of make you think that there's just a really complex process going on that could be managed tons of different ways, depending on what it is or what the specific scenario is or what kind of drowning it was. But really, ultimately, this misses the entire point, okay? Back in 2002, there were 33 different definitions of drowning. If you look through the medical literature, how can you expect anyone to know what the hell you're supposed to do when there are 33 different ways to interpret one thing? But in 2006, there was a World Congress on Drowning, and they laid out a uniform definition of what drowning is, and really, emphasize that we don't use these other terms because they really confuse the situation about what's going on and make people think, that they really have to figure out what exactly kind of thing happened and what's going on with their physiology in order to take care of someone, which truly is just not the case at all. And it doesn't really represent the actual physiology of what's going on. So what drowning is defined as, based on this World Congress, is a process of experiencing respiratory impairment from submersion or immersion in a liquid. Okay, this is very general if you think about this, right? It's the key, though, that we really highlighted here is that this is a process. Okay, what happens with processes? Well, processes are a continuum, right? A process is something that can be corrected, or you can stop a process. You can, in fact, even reverse processes. Okay, so I think that really really better represents what's going on, rather than having all these different definitions of, is this a dry drowning or a wet drowning or a delayed drowning or secondary drowning? And really, if you think about it in terms of this as a process, that will really help you know what to do when someone experiences drowning. Okay. So, I mean, if someone falls in the water, inhales a little bit of water, is coughing, and feels a little bit out of breath, is that drowning? Yes, right. They're experiencing respiratory impairment from submersion or immersion in liquid. So you get splashed in the face a bunch of times, and you're coughing and having trouble breathing. That is drowning, right? So one thing we do know is if this is a process that involves being in liquid, it's not dry. There's really no such thing as dry drowning, and that kind of confuses the whole point, right? Like there is no such thing as dry drowning. Drowning is inherently involves water or liquid. Okay, so just get that out of your mind. It just doesn't need to be that complicated. Okay, there's 3 things that can happen once someone goes through the process of drowning. So either it's non-fatal and there's no morbidity. And morbidity is a word that we use in medicine that kind of really means, is there some kind of lasting ill effect? So are you back to normal, or is there something wrong with you as a result of this this drowning episode? Okay, so there could be non-fatal, no morbidity. You're totally fine. You fell in, you took a bad swim, got worked in a hole for a little while, you came up, you coughed for a little while, took it easy, felt better, continued on with your day. You had a drowning episode, it was non-fatal, and you were fine afterwards. All right. And thinking about that process, we were just very early in that process. We stopped it and we reversed it. It was fine. Okay. Now there's non-fatal with morbidity. So think of this in terms of, a heart attack. Just like we don't have a near heart attack or an almost heart attack or secondary heart attack or something. We either have one or not. It's a process also. And you can have a heart attack and you have a blockage to one of your coronary arteries. You go to the hospital, they open it back up, you go home, you're fine. Okay. You can also have a heart attack, just like a drowning, where you end up with permanent damage to your body as a result. So this would be the situation where you come out of your boat, you get swept into a sieve, you may get pinned there for a while, you get pulled out, you need CPR, they get you breathing again, get your heart started again, but you've got some brain damage as a result. And that's going to be non-fatal. You drowned, you had a process occurred, it was able to be reversed, but unfortunately there was irrecoverable damage to your brain as a result of that. And the third one, which is what we classically think of as drowning, is that you can get stuffed into a sieve, get pulled out, unable to be revived, and you die. And that is also drowning, but that is a fatal drowning. So hopefully that makes it a little bit simpler and really sets your mind up really to think about what is going on with drowning. It's this continuous process. So it really has several phases. So if someone goes into the water, we think of this as about 10-minute process of drowning, where ultimately after 10 minutes, most people will have a fatal drowning or will at least be in cardiac arrest. So their heart stopped, no longer breathing within 10 minutes. So the first stage is like the surprise. So you're in the water, your body is surprised. Okay. And unfortunately, a lot of people never make it to the next step because sometimes you can inhale a bunch of water and then this process becomes accelerated at that point. The next phase there, you see the girl with her hands up underwater, is involuntary breath holding. So this is kind of the nature of humans to try not to breathe water. So we are meant to breathe air and drink water. And if you try to reverse that, it gets weird. So we try to keep the water out of our lungs inherently. It's an actual physiologic reflex to try to hold our breath. So it's involuntary. If you're underwater, your body will kind of keep you from breathing. So, at a certain point, you either have the drive to breathe, which is kind of mediated by the levels of carbon dioxide in your body and your level of oxygen, will either overcome that and you'll be taking a big gas of breath of water, and then either water will enter your lungs, usually not very much, or your vocal cords will spasm shut and keep the air out of your lungs. But regardless, you haven't breathed in quite some time at this point. So what's happening to the level of oxygen in your body? Well, it's getting very low. Okay. So once you run out of oxygen, you become unconscious. Okay. Eventually, the level of oxygen gets so low that you begin to convulse. And then after about 10 minutes or so, really anywhere really from 3 to 10 minutes, depending on how much oxygen your body needs. And typically, if you're swimming in whitewater, you're going to have a very high heart rate, very high metabolic demands. So your muscles need a lot of oxygen. Your heart's beating really fast. It's going to happen probably quicker. At that point, once you run out of oxygen, your heart will no longer be able to beat, and you will suffer cardiac arrest. Okay, so you think about it. You can intervene at any point along that process by reintroducing oxygen into the equation. So if you think about it here, the oxygen level in your blood starts out at 100%. Unless you're up at high altitude, most people have 100%, at least a 96 to 100% of their hemoglobins, their blood cells running around, have oxygen fully attached to everywhere. As you start the process of drowning, which is a process of not having oxygen going to your, entering your lungs, eventually hit this point of unconsciousness. At a certain point, you start to develop injury to your brain because there's no oxygen. And then that becomes even more severe once you get to the point that there's such low oxygen levels that your heart can't even support it, then you will die. The key thing to point out here is that the brain is the most sensitive organ in your body to a lack of oxygen, and it doesn't have a big buffer. It doesn't take much to hurt it. Your kidneys, other things can go without oxygen for a long time, but not your brain. It only has minutes. Okay, so when you think about drowning, you can kind of think to yourself, is this a lung problem or is this a brain problem? Well, most of the traditional treatment and first aid and ways that we have culturally and historically thought about drowning is as a lung problem. However, I want you guys to think of drowning as a brain problem. Okay, that will help us do the right thing to people who are drowning. Okay, just because it's a brain problem, though, because the brain is so sensitive to the lack of oxygen, it doesn't mean that we don't need to be worried about what's going on in the lungs. Okay, what's going on in the lungs is pretty important because the lungs are how we get oxygen into the blood. Okay, so this is a little picture here of alveoli. It's unfortunately a bit grainy. It didn't blow up quite as well as I'd hoped, but you got here is these tiny little network of little air sacs. If you think back to just even high school biology and stuff, if you spread them all out, they'd have about the surface area of a tennis court inside your body. So these things are tiny. They're about one cell in width, and they're covered by a tiny little network of capillaries that carry the blood around through there, and they let the oxygen diffuse across the cell into the blood, and then it lets the carbon dioxide come back out. So in order to do that, there has to be this little soapy layer on the inside called surfactant. Okay, surfactant is the same sort of thing that's like in foaming soap or like in Dawn. It breaks up surface tension, which is why if you have, oil on the surface of the water and you to pour Dawn soap and stuff on there, it actually breaks the surface tension up and then dissipates the oil, and it makes the oil sink. So think about that, the soap in your lungs. So what goes on in the lungs when water gets in there or there's no oxygen in there? Okay, well, it actually makes really big foaming mess, just like if you would put soap or surfactant into your dishwasher, introduce water to it, and then started shaking it all around, you would have a huge mess in your kitchen. So similarly, if we get water in our lungs, it kind of washes away some of the surfactant. Okay, and I'm going to show you guys some pictures and videos that may be a little bit graphic, but these are all medical cases of people that are experiencing drowning, just so that you guys can see what it will look like if you do experience someone that's drowning, and you hopefully won't be shocked or not know what to do or not know what's going on, so that you can actually see some real pictures. So this is somebody that has experienced drowning, okay? And this is the foam that's coming out of her nose, okay? So this is like, it's thick, pink or white, very airy foam. This is not vomit, and this is not water that's in their lungs. This is a bunch of fluid that mostly is coming out of your blood vessels and caused by inflammation and injury to your lungs. And it has to do with that little soapy layer that's inside of your lungs. So think about it as someone put a little soap into the dishwasher and then created a big soapy mess. So if you think about it, if you came into your dishwasher still running, okay, with full of soap, filling your whole kitchen up with soap, and then you try to take a spoon and you started trying to clean it all up with a teaspoon. Okay, that's essentially what you'd be doing if you try to suction that foam out of their nose and mouth. It is still coming. The dishwasher's still on. It's going to just keep coming. You can't make it stop. So, so that's pretty important to realize. The way this actually happens is not necessarily so much that there's a lot of water in your lungs. In fact, there's usually very little water in someone's lungs. At autopsy of people that have died from drowning, they'll usually find 2 to 3 liters of additional water in the body, most of which is usually in the stomach, very little of which is in the lungs itself. But what happens here, if we talk about this little capillary bed that we had, so one of those little alveoli, those little air sacs, gets the surfactant washed out, and then it can't diffuse oxygen across there. So your body tries to say, well, this little air sac isn't working, so we should send blood to other ones that are working, because we're just wasting blood going around and around these little air sacs that aren't getting any oxygen in them. So it actually it constricts those things, and then it sends the blood elsewhere. Well, the problem is that increases the pressure on the other ones, and then the one where it's constricting, there's actually doesn't get any blood flow to it to perfuse those little cells, and so the cells start dying. So then we start to get a lot of inflammation and stuff in there. So and then when those cells die, it allows fluid to leak back into the airway from the blood. And so a lot of that stuff you're seeing is actually fluid from the blood coming back out of your lungs, not the water that went in when they were drowning. And the reason why this is important here, this is again one of those videos of an actual drowning case. So if anyone is particularly bothered from this, you may not want to watch it, but it's really helpful to see. So this is on a beach. This guy was pulled out of the surf, and kind of based on their understanding of drowning, they need to get the water out of his lungs. And you'll see that there's foam coming out. But, unfortunately, as we realize, that's never going to stop. And that's not really the problem, right? The problem is that there's not oxygen in his blood is going to his brain. You're never going to get all that foam out. Essentially, the dishwasher is still running. Okay. So if we think about it as a brain problem, we really want to think about how this is different from a cardiac arrest that happens when somebody has a heart attack or abnormal heart rhythm, like we typically learn about when we take CPR class. If you're at the mall and someone collapses, the reason typically is not that they ran out of oxygen and their heart stopped. It's because their heart had something go wrong with it that went into a bad rhythm that you just suddenly lost blood pressure. Okay. That's why when we think about, you want to identify why someone's heart stopped, why someone's in cardiac arrest, we've got to think about them running out of oxygen and prioritize giving them oxygen back. Okay. So this video is another one you guys may have seen before, but and I've sort of truncated it here, but I just kind of want to set the stage for you on a real rescue that could have gone very differently here, where this person was pinned face down. Okay. So imagine you're in this scenario, you've got someone up underneath a rock, and they've now spending some time face down. Kind of, the rest of the video up to this, they were head up for a while, but you can see they've got a small air pocket, and he's trying to get them out. Okay. But at this point, now there's no air pocket. Patient is face down underwater. Okay. So think about what's happening now based on what we were saying before. We're in that initial phase of drowning where we're still in a very reversible point. We have not gone long enough that the oxygen levels have really dropped too low, and now we've got them out. Okay. So if you think about what's going on now, you're pulling this patient out to shore. You've got their head out of the water. Now what, right? Now what do we do? So we kind of depends on what's going on with the patient. So most of the time in these scenarios, hopefully you don't encounter something this bad most of the time, but most of the time if someone's been underwater, either with a bad swim, been in a hydraulic, been pinned briefly like that, they're going to come out. They might be coughing, but they're not going to have any foam at their nose and mouth. And if you just put your ear against their chest and listen to their lungs, they probably won't have any abnormal noises. It'll just sound just normal. Okay. Really at that point, that person has a 0% chance of dying. So if they just have a cough, there's no foam, their lungs sound fine, those people can be observed for about 4 hours or so. And then they have essentially, if they don't progress to any more of these signs, they will be totally fine. And we can talk about that more later on, but they don't read anything else. But if you kind of go down this this grading scale here, if they have a small amount of foam and their lungs don't sound quite right, these people need to go. All right. They are going to need oxygen. They've got a less than 1% chance of dying, but it's real. Okay. Definitely not someone I would feel real comfortable hanging out with for a long time in the backcountry. If they got a lot of foam, but their pulse is still normal, you can feel the pulse at their wrist, kind of assuming that they have a normal blood pressure. They have about a 5% chance of death, but definitely you need to go to the hospital. Really, once you see there's a huge jump, once you start to notice that someone has some signs of abnormal pulse. Okay, so their pulse is low. Not low, but if they have weak pulse, you can't feel it at their wrist. Let's assume they have a low blood pressure and there's a lot of foam coming out of their mouth. These people now automatically have a 20% chance of death, even at the hospital. And if they come out not breathing, 44%. And then if there's no pulse, 93% chance that they will not live. And that's not even considering, will they have even a good outcome? So essentially, we want to intervene as early as possible to try to prevent this. Okay. What's not important for you to remember any of these numbers or any of these things, just to kind of demonstrate the continuum here, that kind of the further down you get, the worse your chance of survival is. So, and really what that relates to is how long the patient went without oxygen. So what do we do? Okay. So in drowning, kind of unlike the person that drops in the mall, okay, we prioritize airway, then breathing, then circulation. So have any of you taken any CPR classes recently, particularly like layperson CPR? They emphasize CAB, or circulation, airway, then breathing. And the reason for that is because, like we sort of mentioned before, the number one cause of out of hospital sudden death is having a sudden heart arrhythmia, where your heart goes into either fibrillation, where it's got uncoordinated movement, or tachycardia, where it's beating so fast that it's not actually having any organized rhythm. And those patients still have, if right up until the moment in time that their heart stopped, they had a perfectly good level of oxygen in their blood. So we can just pump that perfectly well oxygenated blood around for about the same amount of time that patient can survive underwater without any oxygen. And they'll still be all right. So you're pumping around that oxygenated blood. So for us, if we started chest compressions only right off the bat, if you think about it, we're pumping around that unoxygenated blood around their body. And so we're not really helping them. The reason that their heart stopped is because they ran out of oxygen. So we need to, number one, start giving them some breaths. Okay. And you're going to want to do that as soon as possible. And I'll show you a few techniques for that here in a second. And then as soon as you're able to get them somewhere where you can do chest compressions on it, then we'll start chest compressions. Okay. One quick note on chest compressions is that you're going to need to, I think this is the PFT that you've really been loving, Zach, but so you're going to need to take your you're going to need to take their PFD off in some way, either pull it off or cut it off. Realistically, I'd try to pull it off because cutting these things can be pretty tough a lot of times. To pull off their PFD or cut it off because that will prevent you from doing effective chest compressions for sure. Okay. The one thing to really think about, though, as a commercial guide in particular, is that your guests may not always be in the best health. They may be also predisposed to cardiovascular disease. And so think about it. Is what happened really drowning, or did this person have some sort of cardiac event that caused them to become unconscious and cause them to either fall out of the boat, or does it make sense that what was going on was truly drowning? It won't necessarily change what you do, but it's just something to be thinking about in your as a commercial guide when you're planning for this sort of thing, and whether you're going to bring an AED or not, which we'll specifically mention before. So, when do you start doing breathing? Well, this here is is Evan Geiselman, I think, pro surfers in the pipeline of Hawaii. This is a great example of an effective rescue. So he goes over the falls, which is, had someone here right here with him, is able to grab him. He's unconscious, still getting splashed and pushed underwater. And you'll see that he begins rescue breathing right there in the water before they get to shore, before they get anywhere else. Okay. So this guy, he ended up being fine, completely recovering from this event. And it's important for us to remember this means that somebody that is drowning is not necessarily suffering from a lack of dry land. They're suffering from a lack of oxygen. Okay. So what can we do to really rapidly intervene in a drowning patient? So if we've got CPR barriers, like pocket masks, things like that, if we keep them buried down in our first aid kits, which are not easily accessible, I think it takes too long to get to, and it's going to kind of be one more impediment to us to rapidly initiating breathing, which is what this patient needs. Zach, can you see my camera?
Yeah, I can now.
Okay. So, what I do is I keep in my PFD one of these really small CPR pocket masks, always in my PFD. And it basically is just a plastic, face shield with a one-way valve in it. That is just one less barrier to me to start giving rescue breathing right there, either still in the water, or right as soon as we get them into an eddy or we pull them back in the raft. I don't have to wait even a minute or two to get something out of the bag. And particularly commercially guiding, I feel like I'd be a whole lot less likely to feel comfortable or want to do mouth to mouth with no barrier, especially in like COVID times, but really never would I want to do that. To particularly someone I didn't know. I mean, if it's your family member, your bro that you're out boating with all the time and stuff, that, you'd be much more likely to do it. But in a commercial setting, we really should be prepared for this. And that also goes in that theme of professionalism. I mean, this isn't an unforeseen thing that you could have never imagined would happen, right? So this is predictably the bad thing that we're trying to mitigate against is a guest drowning. So taking sort of steps to prepare for it, like having the right stuff, I think is critical. So this shouldn't be improvisational. You should be preparing that this is going to happen, because this is the worst thing for the most part that can happen to one of our guests. So how can we do that even better, right? So mouth to mouth is okay. All right. It provides a little bit lower level of oxygen than if you're just using ambient air, which is 21% oxygen. And it's about like 16% oxygen when you exhale it again. So it's still pretty good. It's better than 0%, which is what the patient has. We can use these great pocket BVMs, right? So this is how big it is. It's very small. I keep one in my kit. Definitely not going to keep it on your person, but it'll allow you to ventilate a patient really effectively with a pretty small device that's only about $40 or so. And when you're thinking about stuff to put in a first aid kit to have with you on a trip, I mean, there's a lot of stuff that isn't going to save someone's life that might just make someone more comfortable. Like, for example, Band-Aids and stuff like that. if you make a little bit of room to have one of these things, it could actually be a life-saving device. Okay. What it does require, though, is some training into how to use it. Okay. So really all I can tell you is that you're going to need to practice. So you can, anywhere where you're going to learn CPR or wilderness medicine training and stuff should have mannequins and things for you to be able to practice on. But it does take practice to be able to effectively use it. And there's certain things about people that can make it very hard to get a seal around their face. Someone has a beard like I do. Certain people that are really obese, things that, I don't know what your rafting guests are like where you are, but in the Southeast, we definitely have plenty of obese rafting guests. So definitely something to practice. I can't really sort of demonstrate or give you any effective techniques virtually like this. It's just something that I got to emphasize. You got to go practice. So, when we were talking about and showing these examples of drowning, what are you going to expect to be coming out of their mouth and nose if you're having to give someone rescue breathing or ventilations or CPR with drowning? Well, there's going to be a whole lot of foam. Okay. So what we don't want to do is do what was done here in this case. So this again is another, fairly graphic video of a drowning case. But what this child was pulled out of a river, and they're focusing on trying to get all of this foam out of their lungs. And again, this is this idea that we have to get the water out of the lungs. You see, this is a lot of foam here, and they'll see they're going to pick this kid up and they're going to try to shake the foam out, try to get the foam out. And you'll see that it's just a tremendous, tremendous amount of foam. Okay. We want to ventilate through it. It's really gross, but it's never going to stop. So we're going to want to ventilate straight through it. So you're going to put the bag valve mask on there and you're going to keep bagging, even though there's foam there. You're going to ventilate, you're going to breathe into their mouth and nose right through that foam. Okay. It's coming from their lungs. It's coming from the injured cells in their lungs. And we can, if we give pressure and we inflate their lungs with some pressure, not a tremendous amount of pressure, but just some pressure, it will help get oxygen in, even though there's foam. Okay. So what about AEDs? This is another great question. As we, as we're professionals, we're planning for these things to happen, right? We have to be prepared for the worst case scenario to keep our guests safe. So is it worth having an AED on a trip? Well, I would definitely say it is, but don't expect it to be really all that helpful in a drowning patient, because really we know that like a very low percentage of drowning patients are actually in ventricular fibrillation, which is the heart rhythm that the AED is going to shock a patient's heart out of. So it really has to be a very specific either ventricular fibrillation or ventricular tachycardia for an AED to work, because in that case, that's what caused someone's cardiac arrest. Now, like we alluded to before, as we've got guests that are perhaps not in the best health, that may be older, things like that we see on particular trips, the chance of them having a cardiac arrest secondary to one of these cardiac events is definitely there. And the AED is the only way to fix that and can absolutely save someone's life. So I think it's definitely something worth having on a trip, but it's just, don't expect it's going to necessarily be the thing that helps your drowning patient. And the other question we always ask is it safe to use an AED on somebody who's wet? Is that going to shock me or anything else like that? And the answer is yes, it is safe to shock a patient who is wet, or even that is on wet ground. You just try to dry them off as well as you can to try to get the pads to stick. So that's the big issue. Like, getting the pads to someone's chest through a dry suit or a wet suit or all those things is going to take a little bit of effort, and maybe is something worth practicing doing in training. So again, let's go back to this big diagram here. So as we talk about drowning, there's essentially, we recognize that drowning is the big kid on the block when it comes to reason people die when they're boating. And you look at this big category on the top, flush drowning, and we had just kind of gotten through saying there shouldn't be any of these other classifications for drowning. Drowning is drowning. But everybody knows, in boating that there's this thing called flush drowning. Does anybody have like a great definition of what flush drowning is? You can throw it in the comments. Zach, you can throw it out there if anybody. There's a great one.
The interesting thing about asking for immediate comments is there is like a 10-second delay with YouTube Live. So we may get a comment in a second. If we do, I'll let you know.
Okay, that sounds good.
I've always thought that this flush drowning category was just a big category for we don't really know what happened.
Yes, that really, I mean, when it gets down to it, that ultimately is what flush drowning is. They've really been trying to categorize like what is it. There's been a couple of articles written in the medical literature, in the wilderness medicine literature, kind of looking at what flush drowning is. It really is this kind of catch-all that we don't know what it is. And so there was an interesting study done a couple of years ago where someone looked at the American Whitewater Accident Database and tried to, and they gave the hypothesis. They thought that flush drowning was in large part could be accounted for by cold water and the physiology of being immersed in cold water. But really, we kind of know that flush drowning, just by definition, kind of is a category where someone was in the water, they died, and we have no idea why, and they weren't pinned underwater. So is this due to the cold water? Is this sometimes a traumatic event? Did they aspirate? Did these people have, they fall in and happen to have a, cardiac event? Were they exhausted, hypothermic? Did they faint? I mean, it's really, who knows in a lot of these cases. And there's really no reliable way to tell at autopsy or anything what exactly happened. But this study was pretty interesting. So what they did is they actually compared the Rocky Mountain region versus the Southeast. And then they sort of subdivided the Southeast up into only the warm months. And then they took and redivided all of these fatal drownings into, or really every fatal accident into an entrapment versus they recategorized everything as a flush drowning themselves, despite what it was listed at in the database. And they went through and basically said no matter what the cause of death was, if they didn't have any observed trauma or a medical issue, and they were wearing a PFD and they were in a whitewater craft, they classified it as flush drowning. And they excluded solo boating because there were no witnesses. And then they kind of redefined all that and then used that as the flush drowning definition, which I kind of by default says that this is catch-all, right? And so the outcomes of this was pretty interesting. So in the Rockies region, 61% of the fatalities were considered flush drownings, and in the Southeast it was only 15%, and the Southeast had 74% entrapment. A couple other things that were really interesting, and they suppose that the water temperature difference was the biggest thing playing into fact, but there were a few other things that I think people can throw into the comments too that they may find that are different in those categories. So if we think about it, this is the Rockies versus the Southeast. And, I definitely think that water temperature may play a part for sure. There's a few other things. So if you looked at the actual demographics of the boaters, the average age of the boaters was involved in the fatalities in the Rockies was older in general. And then I always really was thinking it was pretty interesting that the characteristics of the rivers in the Rockies and the Southeast are very different also. I mean, as a Southeastern boater who's, only kind of visited to boat in the Rockies and things, sort of geologically, they're quite different. Particularly as the Southeast, we've got these ancient old rivers that have lots of, polished boulders. We have tons of wood, and then we have a lot of undercut rocks and things that are not as the kind of features of these old rivers, and also tend to be kind of drop pool versus, the sort of geologically young Rockies that has kind of sharper rocks, has more long continuous sections of whitewater, and not as so much drop pool, which definitely could play into it as well. And that kind of could explain some of the differences. Some of the things we that we don't know is like, what is the average age of a boater like in general in the Southeast versus the Rockies? Like, is that part of the reason too? It's hard to say, but be interesting to see what some of the folks comment on this too, what they may think. Might be some of the other things that could be accounting for these differences in the flush drowning between the Rockies and the Southeast. It may be the water temperature, but it may be a bunch of other stuff too. Another really interesting thing that came out of this too was looking at equipment entrapment, like pretty relevant for raft guides, is that equipment entrapment was by far more common in rafters than it was in hard boaters. And one of the most interesting things to think about too is that rope entanglement was like almost exclusively among inflatable boaters. So that really something to think about before you deploy a rope in the water, is that you could definitely make your situation a lot worse. And that seems to be much more common among both commercial trips and inflatables rather than hard boaters. So
Chris, some of the comments, some of the comments that people left is Carl wrote, flush extended swim. That was like a question.
Yeah.
Denise wrote, flush drowning, what Zach said, including cold water related CA, which I'm guessing is California. I don't know what CA means. I know in California there's a lot of cold water things.
Yeah.
And Jesse wrote, I've always understood a flush drowning as no specific event, just relentless waves or swim.
Yeah, absolutely. And that's one of the things too, the relentless waves, the long swim. Like I think that was kind of a little bit underappreciated, at least in this analysis. And like as boaters, like thinking about it is, it's hard for me to find somewhere in my local creeks and stuff where I'm going to take a swim that's going to be minutes long. Like there's most of the time you're going to get beat down for a second, and then you're either going to get pinned in something or you're going to be in a pool. And a lot of the the rivers in the Rocky Mountain Range, I mean, you could be swimming for a long time without being able to get out of continuous waves and holes. So it's a very different characteristics. I think it might have a lot more to do with it than necessarily the water temperature. So, because we have a lot of cold water too in the Southeast. So anyway, I think it warrants a little bit of a discussion of like what actually happens when you go in cold water though, because it can really help us try to keep people from having a bad outcome when they're out there boating. So there's these 4 stages of cold water immersion. Then this was based on research that was done, with Navy divers and stuff like that. It kind of laboratory based stuff. But so the first stage, we can I certainly can relate to this as someone who's experienced all this before. I'm sure you all have too. But so the stage 1 is this cold shock. And this is mediated by like all the skin receptors sensing cold water. And how strong this response is has to do with how fast you're cooling. So really starting at 73 degrees in the water temperature, you can start to see this response. And obviously, the colder it is, the more pronounced it is. But 73 is not that cold of water at all. What happens is there's this involuntary gasp. So you're going to take a big deep breath in, and you're going to start hyperventilating, which has its own issues in and of itself. If you hyperventilate, if you imagine someone's like having a panic attack or gets really nervous, they breathe super, super fast, eventually you'll get dizzy and faint because your level of carbon dioxide will drop too low. That certainly is bad if you're in the water to faint. Okay. It's also bad to hyperventilate if you're trying to time your breathing going through big waves splashing you in the face. Okay. That involuntary gas can cause you to breathe in or aspirate water right as you go into the cold water. You'll rapidly cool, which will begin to have some effects on you as well. And it also causes all of your little tiny blood vessels on your skin to contract down to try to keep you from losing more heat. Okay, and that has some impacts on your body because it actually increases your blood pressure sort of centrally. So if you're older or somebody with some problems with your heart or big blood vessels, that could cause trouble with that. And also you'll end up with a really fast heart rate. Okay. So this process lasts about 5 minutes or so, kind of in the lab. But realistically, you can control some of these things. We know through practice or repeated exposures and stuff, you can control your hyperventilating. You can prevent rapid cooling. You can't really prevent the vasoconstriction, though. Like, that's going to happen no matter what. So kind of after that 5 minutes or so, you're going to enter stage 2, which they call swimming failure. So this is going to be as your extremities start to get cold, your like nerve conduction slows, so you can't actually, you lose some of that fine motor coordination even before you're actually hypothermic. You know, if you're just, your hands are cold and you get fumbly and you can't do things, you could be perfectly warm, like as far as your core temperature, but as your hands and stuff get cold, you just kind of lose the ability to do fine motor tasks. Sometimes this hyperventilation can lead to fainting. And if you pass out, obviously you're not very good at swimming. So this sort of swimming failure thing, they sort of in the lab take about 30 minutes or so. And then you move to stage 3, which is the hypothermia. So at 30 minutes, like a submerged individual in 41-degree water, 30 minutes is what usually it takes to get like significant hypothermia. So really, particularly if you're wearing any sort of protective gear, you're rarely going to be in the water 30 minutes before you get rescued. It's bad. I mean, it certainly can happen, but that is super bad. And so in a lot of these cases of flush drowning, people were not in the water nearly long enough to have actually died of hypothermia. So things that can make the hypothermia worse, though, is obviously pre-cooling. So someone that has been out all day not wearing the right stuff, and also the fact that the water's moving around us actually enhances the rate of cooling. So things that we can do to stop this, right? So warm gear, having on a dry suit or wetsuit, that will sort of stop that rate of cooling. So that's really key. So as you fall in the water, if all of those sensors in your skin don't get rapidly cooled off by getting splashed into cold water, they're not going to hyperventilate as much. They're not going to have as much of that constriction of their blood vessels. They're not going to gasp as much. So that's super helpful. So that's why, like, in addition to being more comfortable and not getting hypothermic, wearing the appropriate outerwear is actually a safety feature as well. Okay. We can't do much about the actual physiology. We can't do much about the actual physiology. We can prevent it through the right stuff, right? So warm gear. So once somebody kind of goes through that process, we can try to prevent swimming failure resulting in drowning by wearing high flotation PFDs, something that's going to keep their head out of the water. It's going to keep them floating high enough out so that they're not getting repeatedly splashed in the face. Okay. We're going to also going to have to get people out rapidly. That will help with swimming failure as well. You know, the longer people spend in the water, getting splashed and getting exhausted, the worse it's going to be. You know, also we can try to minimize the number of ropes in the water. We'll know that if somebody gets entangled once they're already cold and they've got diminished fine motor skills, their ability to get out of that rope is going to be even diminished. So using a knife, cutting the rope away, holding onto it, or even untangling themselves will be definitely diminished. And then kind of lastly, the hypothermia. Also, that warm gear is a good insurance policy against the hypothermia. If they're not pre-cooled to begin with, they're going to be in much better shape if they do end up in that cold water. So anyway, some take-home points for you. So after all of this, 30, 40 minutes of talking about drowning, I want you guys to remember that drowning is a process that's a brain problem, okay? You don't need to get stuff out of their lungs. You just need to get oxygen into their lungs, so that needs to go to their brain, okay? Don't wait to give them breaths. Bring something with you that lets you rapidly start giving rescue breaths, okay? You're going to breathe through that foam. You're not going to get it out of there. It's never going to stop. That dishwasher is still running, so you've got to give them air and oxygen back without having to worry about that foam, getting the foam out. Okay, wear an appropriate PFD. Don't be drunk. Those are two of the things that are associated with drowning fatalities: is not wearing PFDs and alcohol use. And then we don't know what causes flush drowning for sure, but it certainly seems that cold water and rivers that are really continuous really play a big part in it. But kind of understanding that a little bit better can help us sort of mitigate against some of those things. So happy to answer any questions you guys have. I've got my email address up there too. You can email me if you've got any other questions or things in the future. I'm going to go ahead and minimize that and kind of get back to discussing anything you guys want to talk about.
Chris, that was awesome. That is super helpful. I learned a ton. I have a page of notes here and a bunch of questions for you. So I'm going to try to intersperse my questions with everybody else. There's been so many nice comments. People are super stoked on this. So thank you so much.
Yeah.
The first one is, I don't know if you can see the screen now. How does or does not water temperature impact the process?
Yeah, so that's a great question. So water temperature, we kind of if we look back at like the drowning case reports and stuff, it does seem that people that are drowning in cold water have a little bit longer time frame that they can be successfully rescued and resuscitated. And that is theoretically because kind of as your body temperature decreases, the need for oxygen by your brain, your whole metabolic rate slows down. And that's the concept of why we actually induce hypothermia in people to try to protect their brain after they've had a cardiac arrest. But that's kind of the process that it happens. For us, though, I think in whitewater, a lot of it does kind of go into that physiology of what happens when you go into the cold water. Sometimes may be the thing that's precipitating us drowning in the first place. So it's kind of hard to say.
And Nick writes this, I've the same way. Like I had a bunch of questions, then you would answer it. It was really a thorough presentation. Good. But I do have some questions that are like trying to figure things out. Is flush drowning an official medical term, or is it just a term that American Whitewater uses for their chart?
It is. Yeah, it is not actually an official medical term at all. That we had a bit of a debate in the super nerdy like wilderness like medical journals where I wrote a response back to that article saying, this is not an official term, but it's like completely academic because I use it and it's a colloquial term in whitewater. And we all know, like if you say flush drowning, everyone kind of knows what that is. Right. So it's not an official medical term at all, but I think it's important. It's an important concept. And I think it's really purely semantics. I don't know if there's any reason to try to come up with another term for it, but it's just something that we've always known exists and it describes, I guess, like a syndrome, almost like a whole category.
So how would you define it?
Gosh, so yeah, almost like I'd say flush drowning is it's sort of an unexplained. And I think flush drowning almost entirely refers to if it's like universally fatal, right? Because it's only a retrospective definition of someone that dies in whitewater that does not have any other clear explanation. So it's basically a catch-all for anyone that dies in whitewater without an alternative explanation.
Okay, that's good to hear because I've always seen it as somebody falls out, you don't know what happened, they die, so they can't tell you what happened, and so you don't know what you can guess it was something, but you really don't know what that thing is.
Right, and you assume it probably and it probably. I mean, in a lot of cases, it probably has to do with drowning, probably drowning. And if it's drowning, it's drowning, right? But we don't really know that. And so that's why I think that's a useful.
But they could have fallen out and had a heart attack right away.
Yeah.
And they didn't actually drown. The heart attack's what killed them, but it's called a flush drowning.
Right, exactly. Because there's no way for you to know that was a heart attack, right? So that's,
So a flush drowning doesn't have to be a drowning. It just has to be something people die after a long swim, and it could have been something that you don't know what it was. They could have had a stroke, and it could have been a stroke.
It could have been someone could have poisoned them with cyanide at lunch, and they fell out. And who knows, right? So
that's funny. The foam stuff was really interesting to me. The visuals were graphic, of course, but it helped me understand what it looks like. I had no idea, and thanks for hammering that in because I really learned a lot that. And what I took away, and I want some clarification here, is if somebody shows a small amount of foam, that's probably an immediate evacuation. That's like you get them out, they show foam, you're bringing the helicopter and you're flying them out.
Absolutely. You know, that was if it's because we think about, we've seen tons of people that have, you know, in our own personal boating stuff that have, you know, coughing or choking a little bit like after they come out from a bad swim, but they're not having visible foam coming out of their mouth, right? And that's a huge difference right there. We know that they've got lung injury. Really, there's injury to their lungs. If they don't, you can pretty safely watch them for a little while. But the minute you start seeing foam, you should probably be getting them out of there.
That's immediate evacuation. If you don't see foam, see, to me, what I took away was if you see foam, immediate evac. If you don't see foam, then you just monitor them.
Right, exactly. You can monitor them, and then certainly if their symptoms are worsening, if they're having trouble breathing, if they're anything else that would make you want to evacuate them, as far as like their mental status is deteriorating, they got any of those things definitely would still apply. But like as far as sussing out the drowning specifically, foam means like evac, no foam, they might be okay. And even with just a little bit of foam, they still might be okay. But like, to make your decision process really easy, you'd be totally solid to just say, foam
as a layperson, now I have a rule: foam evac, no foam. It's a decision to make, like it's gray area. You mentioned lung sounds, foam and lung sounds. Yeah. I don't carry a stethoscope with me. Do I just put my ear up to their lungs, or do you hear it visibly?
Absolutely, yeah. So you can just like put your ear against their chest. I mean, all that the stethoscope really does is let you separate your face from their chest, but you can listen directly to their chest. That certainly would be kind of reserved if you feel comfortable assessing what the sounds are and making a decision based on it. It would be definitely more sort of sophisticated decision making. But as the people get more and louder lung sounds like that, you can hear them audibly while someone's sitting there. And certainly, if someone's sitting there breathing and you can hear audible crackling without a stethoscope or anything, then you know that it's pretty severe.
And that's an evac. Audible crackling would be. Would you have audible cracking without foam?
You could have audible crackling without foam. Yeah.
Here's another question Jesse has about foam. It's funny that we're talking about drowning, but the talk is really about foam.
So I not for the foam specifically. If it's just foam, you can just keep ventilating through it. If you've got like vomit or any sort of stuff in there, you would definitely try to clear that out. But the foam itself, if you can kind of sweep some off, when you're putting it on there, but just the ventilating through it ought to take care of it.
Okay. So the CPR on the water, or the rescue breaths in the water thing, is super interesting to me. I'm trying to figure out how do I know to do that? If my buddy just swims and he's like a little non-responsive, I'm not going to go start making out with him. Like, are you listening and feeling? Are you checking a pulse? Are you okay? Are you okay?
To be breathing, I would try to breathe for them. It'd be pretty hard to tell, but like if someone looks blue and they don't seem to be gasping for breath, I would try to breathe for them. Okay, and so realistically,
if they're non-responsive, is that just enough?
Yeah, if they're not responsive and it doesn't look like they're breathing, that's enough. And you think realistically, we're probably not gonna be like in the water with them most of the time, unless we're doing some sort of live bait rescue. Like you're gonna be usually pulling them into the raft or pulling them into an eddy or something. Because it's unlike sort of like surf lifeguard and stuff like that. We're not typically like swimming out to people, most of the time. But we're gonna have them kind of somewhere. Typically, like even that guy pulled her out. We were in the eddy, So
if I was kayaking and I pulled somebody unconscious up, I would maybe just put them on my deck as fast as I can and give them rescue breaths. Absolutely. Right there, because the rescue breaths are really important.
Exactly.
I think a lot about the CPR barrier, putting in my PFD. Do you protect it somehow? Do you put it in like a Ziploc bag, or you just throw it in there and
I just throw it in there? It seems to be fine. I had that one in there like over a year, and it's I just unfolded it the other day, and it still works fine. So some of them have paper filters in them. So I would try to avoid the paper ones, but even if they are paper, they'll probably be fine for, 6 months or so. And they're cheap. They're less than $1 each. So I got this whole bag of them on Amazon for $8.
I mean, you can just have a bunch and replace them every year pretty easily.
Oh yeah, easily.
Okay, and I think my last question, I'm going through my notes here and finding my questions. So you mentioned stage 1 for cold water immersion. Does, if I fall out in 73-degree water, let's say I fall out in 71-degree water,
Yeah,
I'm not going to have an involuntary breath, right? Because I do it all the time.
exactly.
But some people, even in 71-degree water, because they rarely fall out in it, could take an involuntary breath.
Yeah, actually, it's interesting because this definitely is something. It's kind of in some of the other kind of scientific literature and stuff. But some of the cold water exposure is your body can acclimatize to it, can get used to it, and through repeated practice. And that's kind of like the military training and stuff. People will intentionally try to blunt some of these responses through training, and you can. But so someone that's frequently boating. Is going to not necessarily even physiologically the same response that someone that isn't, which is important. Like as a professional guide, something that we are out there a lot more than our guests, and we can kind of take for granted sometimes, like what it feels like to fall in the water if you are not used to it. So,
no, that's what got me thinking. And I just said involuntary breath, but I think you said involuntary gasp.
It's a gasp. It's just. We've all done that, jumping into the cold lake or something like that before.
But does that gasp, I think you kind of alluded to this earlier, does it take on water, which can then get into your lungs and cause like an early drowning process?
Yes. So that is one of the things that can happen with that, is that if that involuntary gasp is associated with a wave hitting you in the face, that can accelerate the process by washing a little bit of that surfactant out of your lungs, like we were talking before, which is important for that diffusion of the oxygen. And that starts the process by damaging some of those little alveoli. And so that continuum can start from the lung damage before you even get to the point where you're submerged underwater and can't get oxygen in and out. So it will kind of start the process.
I love that point that you made about that the guides are used to falling out, and that we forget that our guests rarely fall into a river. I mean, I think about that a lot. Like as a professional guide, you have to realize, like, just because you're swimming in this river all the time doesn't mean somebody can fall into it and have some sort of action that can cause some damage.
Yeah. I mean, that's like the biggest thing I think about, like taking people out guiding. It's like, I'm on my rivers where I'm all the time, been for years and years. And I feel casually walking around in this eddy or whatever that, if you really step back and think about it, like, I would not want someone else here because like I know about like how to get back, get back to the eddy or where to not be and stuff. But if someone completely unaware could, accidentally take a terrible swim, and so that just kind of that awareness, I think, is a key part, as kind of as we're focusing on professional guides here, is critical to have that mindset that you're talking about.
Well, the last thing I want to ask you about is talking about defibrillators. What are those called again? The
AED.
AED, sorry, the AED.
Yeah.
Can somebody just go buy one and bring it with them? Is there licensing with them? Are there regulations, or you can just go buy one and have it?
Yeah, you can. I mean, you can buy these things on the internet. I'm pretty sure they're pretty much universally available without prescriptions now. That you used to have to get a prescription for it, but they've become unregulated to the point that people can just buy them online. And they're not, to get a really compact, high-tech one that's really small, they may be fairly expensive, but you can get any AED for as little as $500 or so on the particularly refurbished models and stuff like that. Yeah. It's pretty low barrier to entry. I mean, you think about particularly in a commercial outfit. I mean, like $500 compared to cost of a new raft or any of those things is pretty doable. So it's definitely something that can be added to a kit.
Well, last time I looked into it, there were just crazy regulations associated with them. And I looked into it again recently. It seems like I can just buy one or bring it, and I don't have to follow any crazy. I don't have to go to large efforts to have one.
No, there's websites that do nothing but sell AEDs to the public. So it's and there's some really cool models now that are pretty small that can be fairly reasonable to bring with you.
Yeah, I'm getting older, and I'm worried that I might need one. So I mean, part of me is like, man, if they're not that expensive, it wouldn't be a terrible idea to have one around the house. As somebody who's just getting up there in years, and it may save my life.
Yeah, exactly. I mean, they're really not a ton more expensive than even like the satellite locator devices and stuff. So
yeah. Yep. Well, Chris, that's all my questions. That's all the questions we have.
Yeah.
Again, I am so appreciative of your time putting this together, for being here today. I learned a lot. It's meaningful to me for sure, but I can tell from all the comments from everybody's super grateful of this like up-to-date information. So thank you so much for being here.
Happy to share this information with everybody. And again, reach out if anybody has any questions at any other time. So
cool. And I know there may be more comments here. Oh yeah, here's a couple of quick comments. In Europe, they're so simple. They tell you what to do and decide. Yep, ours do that too. It says shock advised, shock not advised.
Absolutely, yeah.
Can you go purchase them? When I last looked into it, it was a lot of bureaucracy to actually get them and then maintain them. And I think they've just gotten better. And just a couple of nice comments from people. So thank you all for watching. And Chris, thank you so much. I hope we can find some other equally fascinating topic to have you talk again if you want to, if you have the time and the energy and the willingness.
I love to. It's definitely this is the stuff I'm super passionate about. So
yeah, no, it's super obvious, and I know I'm super appreciative. So thank you so much, everyone. And this is recorded live. So if you want to share it with friends of yours, or also people will watch us afterwards. So just if you have comments, leave it down in the comment section below, and I'll forward the comments on to Chris, and hopefully Chris can get on the YouTube channel and answer those there. So thanks, everyone. Thank you, Chris.
All right. Take care.